Hi, my name is Duncan Reid. I am the director of EthnoMed at Harborview Medical Center in Seattle, and I'm a clinical assistant professor with the University of Washington. Today, I'm presenting TB cultural profiles, reducing barriers to tuberculosis diagnosis and treatment in immigrant communities. Lessons learned. So I'll provide a background and overview of the TB Cultural Profiles Project, community findings and lessons learned, as well as acknowledgements and next steps. So in the hospital, I'll often start with a case presentation for residents. For example, here's a 60-year-old man from the Marshall Islands with kidney disease, recently developed a productive cough and weight loss. So I'll ask residents, what do you know about the Marshallese community, and how could that knowledge inform your care? Residents will often say, yeah, I took care of someone from the Marshall Islands, and I'll ask them, what did you know? And they're like, well, he was pretty sick, and he didn't speak English. Here's an abbreviated form, but I'll show them a picture of SpongeBob SquarePants, who lives on Bikini Bottom, which is actually based on Bikini Atoll in the Marshall Islands. We'll go on Google Earth and we'll look at the map and we'll see where the Marshall Islands are. We'll look at Bikini Atoll itself and see this crater caused by an atom bomb. And we'll learn that the US military has been using Bikini Atoll as a testing site through 1958 for over 20 nuclear warheads. The Marshall Islands is also a high TB burden country with an estimated TB incidence of about 500 cases per year in 2019. I show them that it's essential to providing patient-centered medical care to have a cultural and historical context. It can inform the provider what diseases should be considered and how best to approach diagnosis and care. So TB is a big problem in the Marshallese community in Washington state. In 2023, over 12% of cases in Washington state occurred in the Marshallese community. Over 100 cases of active TB were reported in King County in 2022, and of these, about 86% occurred in people who were born outside the US. This pie chart shows some of the countries where people were from. However, only 20% of those eligible for TB screening based on country of birth were screened in the University of Washington primary care system. And it's suspected that many community centers have a similarly low screening rate. So our TB Cultural Profile Project represented a collaboration among Seattle King County Public Health, TB program, with a specialized community navigator program representing over a dozen communities impacted by tuberculosis, EthnoMed, based at ethnomed.org, a web resource based at Harborview Medical Center focused on cross-cultural medicine, and HealthBoy Clinics, a primary care clinic, a system which serves a large immigrant population in King County. So we conducted community interviews and produced TB cultural profiles, recordings, and podcasts. So we created high-quality audio recordings of all interviews. We performed a collaboration with the healthcare podcast, Healthcare for Humans. And we also created social media posts, which contain highlights from interviews and community events. So for our TB cultural profiles, we have completed 56 interviews with 81% participants spanning 14 distinct communities that are present here in King County. So here are some of the lessons learned across community. So some common themes that came up is overall, there's awareness of tuberculosis and the main pulmonary symptoms associated with it. However, nearly no one, even healthcare providers, was aware of latent TB infection as a distinct entity. There was also a lot of stigma regarding TB, common across communities, and there's a generational gap in understanding where older generations were more familiar with TB and the younger ones were more oblivious to it. There was a lot of confusion across communities as well. One was understanding the difference between diagnostic methods for TB disease and latent TB infection. So Mantoux skin testing, blood testing, including quantiferon and chest x-ray. There was also confusion regarding treatment options for latent TB infection and TB disease, including the duration, types of medications. There was also a lot of confusion regarding the degree of protection provided by BCG vaccination. In fact, a lot of participants were not even sure if they had received the BCG vaccine themselves. There's also variation across communities in terms of the lessons learned. Some communities are more familiar with TB disease than others, based on either first or secondhand experience. Only some communities associate TB disease with HIV infection. We also noted different levels of exposure to public health education in the various home countries. Some communities receive higher rates of testing in the US based on employment, for example, healthcare workers, and are tested regularly. In these communities, there is suspicion of false positives. Individuals of some communities are also much more willing to share health diagnoses, including TB, than other communities. Lessons learned, Marshallese community. So participants noted there's a reluctance of patients to discuss TB with new providers. Travel is a common barrier, with only one car oftentimes per extended household. There's also difficulty accessing translators, even telephonic ones. There's a reluctance to participate in public screening events due to stigma, concern that results could jeopardize employment. TB screening and care are of lower priority compared to other health concerns. Common complaints of side effects from latent TB infection treatment. Some lessons learned from the Kenyan community. Many community members work in the healthcare field, which requires annual PPD skin testing. So there's an increased awareness in this community of false positives in the setting of prior BCG vaccination. During our interviews, we also became aware of 2 cases of isoniazid-induced liver failure in the community, of which most community members were aware. So healthcare professionals and religious leaders were advising against latent TB treatment because of these 2 cases of liver failure, and there was a sense of suspicion of the US healthcare system. We also interviewed a community member who was diagnosed with TB disease, and he discussed losing his housing, and he no longer interacts with his community. Some lessons learned for the Congolese community. So there's a close association in people's minds between TB and HIV, and there's this double stigma. There's also difficulty accessing healthcare depending on immigration status. Many Congolese in King County are recent immigrants with refugee or asylee status, and there are many competing economic and health concerns. There are also different levels of baseline health education depending on where they're from, whether they're from an urban or a rural setting in the Congo. In the Cambodian community, many Cambodian immigrants arrived in the early 1980s, escaping civil war and genocide. Many community members last had direct experience of TB while in refugee camps in Thailand, and there's an element of re-traumatization recalling that time. There's also a significant generational divide in awareness of TB between the older and younger Cambodian generations. In the Afghan community, they noted there's a significant social stigma. A history of tuberculosis in a family could affect marriage prospects. Accounts of those diagnosed with TB disease provided their own specially marked dishware. Some community members felt that TB was confined mostly to other ethnic groups in the country and really didn't affect them. Multiple community members warned against providing a TB diagnosis directly to a patient out of concern for their mental health. In the Vietnamese community, we again noticed this generational divide in familiarity with TB. Most respondents were not aware of the term TB. Instead, they used a less specific term for lung disease in Vietnamese. Most respondents were not aware of any relationship with HIV. They also noted that it remains highly stigmatized, with many community members preferring not to talk about TB openly. Here are some lessons that we learned about project implementation. First of all, building trust is essential. Community liaisons can help, but meeting face-to-face with plenty of time to build rapport is important for these interviews to work. Communities are also heterogeneous. Immigrant communities are often subdivided by region, language, ethnic group, and language. It can be difficult to generalize about immigrants, even from a single country. There's an importance of meeting the community close to where they live. Community centers and public libraries provided ideal spaces for interviews and were much more accessible than the hospital. Interviews with more than 3 interviews can be challenging. Cultural dynamics involving age, gender, and status can affect how much participants are willing to participate in group settings. High-quality audio recordings are possible. Recent advances in consumer-grade audio technology allow for high-quality recordings for podcasts and educational use, as well as automated transcription. So here is a layout of our TB community profiles. Profile sections include summary, recommendations, methods, as well as some of the data that we get from our interviews. And here's a screenshot of our Marshallese TB profile, which is up on our site at ethnomed.org. We also produced 3 podcast interviews in collaboration with Healthcare for Humans that can be accessed on the internet. We also produced TB campaign materials, including the work of professional photographer Nitya, who's been taking photos to be used in community-level TB information campaigns, and Catherine with Public Health developing videos. We also produced some informational posters for internal awareness at the hospital of our community outreach, here with the Samoan Navigator, and here with Cambodian community. So the next steps, one is to have interviews with primary care providers to see their side of the equation and to understand barriers to testing and care from their perspective. We're also planning on revisiting communities, increase community education and outreach, and also elicit other medical concerns. TB is typically lower down on the priority list for most patients, so what medical topics need more focus? And we're also in the process of publishing TB profiles for 12 communities. Marshallese is up and online, and the others are in progress. We'd like to thank the Tuberculosis Elimination Alliance mini-grant program for the funding that made our project possible in the first place. Our other partners include Public Health Seattle King County, Health Point Clinic System, and Interpreter Services Department at Harborview Medical Center. There are too many people to list who have helped this project forward. Please visit us at ethnomed.org. We're on the socials at ethnomedUW. Here's a QR code. And feel free to email me, Duncan Reid, at reidd@uw.edu. Thank you.